So Alejandro sir, you will be the first one to speak.
Excuse me, what did you say?
Sorry, I can't. Sorry, I can't hear you.
Am I audible to you now?
Yeah, at the moment, yes.
Okay, sir, you will be the first one to start the session.
Who is that?
So you will be the first one who will be starting the session.
Me. Dr.
Yes.
Nazab, is it? Okay. Yeah, well, what would you like to know, actually?
Hello?
Yes?
Just a second, sir. I was speaking to Evelyn, sir. Hello?
Hello.
Abdul Nasser, sir, we have got a lot of things to know from you.
Yes, quite a lot, sir, actually.
Yes, sir.
I think it will be nice to have a question and answering sort of session. So
yes, sir.
We'll be asking questions, sir. It will be in the same manner. We'll be asking you questions. And,
okay.
Yes.
Okay, fire me the first question.
I know, sir. We have not gone the live. I think we start with the.
Hello, can you hear me?
Aspects first.
Hello, moderators,
yes.
Can you hear me?
Parvati, yes.
So we have started live streaming. I think you can begin the program maybe in about 1 or 2 minutes. So let the viewers start coming.
Okay.
If you could just give a command.
Pardon?
If you could give a command when we should start, after 1 or 2 minutes. Okay, thank you, Parvati. You can continue, Kavya.
I'm afraid if Alejandro sir is hearing me.
Dr. Alejandro?
Sir, can you hear us?
Dr. Alejandro?
Yes, I can hear you well. Yeah.
Oh, okay.
Yes, sir. Okay. So we will be beginning the session with you, sir. Alejandro Avelino, sir.
Okay.
Pardon me for my terrible pronunciation.
Yeah, sure. I'm here.
Okay, sir. So we'll be beginning the session in like 1 or 2 minutes. And we'll be starting the session with you, sir. Okay, we'll be asking questions with you.
Hello, moderator.
Okay.
Yes, Parvati.
I think you can begin now.
Okay,
Kavya.
So I request all the delegates to mute your mic, and only when instructed you need to unmute and speak. So I think we are going live now. So okay, Alan, you can mute now. Alan and Alejandro sir, you can mute now.
Yeah.
Once we pose a question to you, you can unmute and answer.
Okay.
Okay. So, good morning, good afternoon, and good evening to one and all, depending on the time zones you are in, joining us live on the session of DAMS MedMeet, the International UG Conference, the World Amidst Pandemic, Will the Human Race Fight It Down? We have delegates from across the world. I am indeed honored to introduce them all to you right now. We have Alejandro Avelino Bonilla, epidemiologist, joining us from Colombia, Dr. Dabota Buhari from Nigeria, Dr. Abdul Nasser, who is working in the United Kingdom and is currently back in home, Dr. Shamir VK, representing Kerala, India, Dr. Shiv Joshi, representing Maharashtra, India, Isabel Levin, representing United States, and Ephraim, representing Taiwan. I welcome all the delegates to the program. Introducing myself, I am Kavya Raj, final year undergraduate student of medicine at Government Medical College, Kozhikode. I am joined by the two co-moderators of the session, Alan Paulos, who is second year undergraduate student, and Nitin Suresh, who is again final year undergraduate student. I think we can begin now. So, 100 years past the past global pandemic, the medical science has advanced a lot. Yet there is something lacking. You guys know that, right? It has been 8 months and the world is still quiet. The world is stand still due to a health crisis. So what is it that we are lacking? What are the parameters that we should have bothered before? And what is now, it is the high time that we start thinking about that. I think we can start it with Dr. Alejandro Avellino. Sir, can you unmute and speak? Yes, sir.
Yeah, hello. Hello, everybody, and welcome to this really interesting webinar. Thank you for inviting me. So let me know.
So, sir, what is it that we are lacking? As I said before,
Well,
health science has improved
yeah.
a lot, but still, we are. It has been 8 months, and we were not able to properly control this, contain this virus.
Yeah. Yeah, I think that what you're saying is really accurate. Unfortunately, we thought we might have really good control over pandemics and over the relationship between countries, but COVID-19 showed us that we were wrong. The WHO thought that every country will answer properly to the pandemic, to the declaration of global emergency, but we saw that we do not have that articulate work that we thought we have. And we also don't have the resources or the media to communicate properly the risk to the communities in every country. And it's really interesting to see how this failed, even in Europe, either in Africa and Latin America. So that makes us think maybe we need to improve the not only the healthcare system. I think that is also the educational system, the politics, the communications, the social media. So this shows us that mankind is not as advanced as we thought. That we had to fight something really simple. We have to say it. Coronavirus is a virus that you can fight just by washing your hands, having some hygiene, and that's basic. So imagine if we have to fight a pandemic more that is more advanced. It might show us that we are really vulnerable and we are not the owners of Earth. So what we are lacking is that we have to understand how vulnerable mankind is and how hard for us is to work like a team, especially internationally. We thought we were going to contain the virus really fast and that we were going to stop it from spreading. But even from today, almost well in Colombia 6 months after the declaration, we saw that it's not going to happen. So we know that we have to live with this. Mankind has to change some habits and also the way it interacts. So hopefully we can actually improve from this, well, this really bad experience.
So, how do we strengthen the host to prepare for this?
Well, strengthening it can be really easy to say it, but it will be really hard to perform. We have to understand that there's also a political dynamic in all these relationships between countries. So a big example is China and USA when they have this rivalry, and then they also have the economic aspect of this. If we have any representative from Africa, we can know for sure that they don't have the economic resources to actually fight the pandemic. And I know from upper hand that some countries they were fighting against dengue, they were fighting against yellow fever, and then just coronavirus came and made it worse. So the social politics of this is so complex. I think it's so lovely to work on it, but it requires will from everybody. But people without knowledge, without education, they cannot focus their will toward things. So I would say the first step will be to actually reach some proper education in every country and also some proper healthcare system in every country because we are seeing that just because you don't have enough money to pay for, it doesn't mean that you cannot access health because you will die and then the economics will go down and everybody will have trouble. So I want you to see how complex it is just to see see people start dying in some countries. Looks like now politics see it as a priority. And another thing that we have to do is to see how important the healthcare system is, and not only as a system just alone, but we saw that it is related with everything. With in the middle of the pandemic, we saw that there is no money for anything. The politics will change, the education will go down, the sales will go down as well. So we have to understand that health is not only health. Health is in every other aspect of life or the mankind life. Yeah.
Thank you, sir, for that valuable words. Now, throughout the course of history, like diseases have ravaged human beings, have sometimes altered the course of history, and also has put civilizations, their existence at stake. Well, even after all these outbreaks, especially the plague outbreaks or the Spanish flu outbreaks, or even the SARS outbreak of 2003 or the Ebola outbreak, and now the coronavirus outbreak, I feel that there are a lot of things, especially the small factors that we are neglecting. That the main topic is the social determinants of health of the people. And now I would like to pose this question to Dr. Shiv Joshi, sir, who is from Maharashtra. Sir, how do you feel, or what do you think will the current situation be if our countries or globally the countries and nations had taken proper measures to implement the proper social determinants of health? So,
Right. Thank you for directing that question here. I think you've raised a very valid point. When we are talking about social determinants of health, what we really need to understand is right now, when we are facing this pandemic, we are looking at lots of acute problems. Okay, so we are looking at people dying with COVID. We are looking at acute shortage in health workforce. We are looking at shortage in personal protective equipment, and at the same time, we are also inevitably going to suffer from a large economic, a large economic loss for the country, right? So there are a lot of acute consequences that we are seeing of this pandemic. But what we need to realize is that beneath these immediate causes that we see today are those deep rooted causes where we failed to work, where we failed to take action much earlier. So these were the points, like these were the places where you need to act before the pandemic actually comes, before any disaster strikes you. So we are looking at parameters like, or determinants like education. Okay, we are looking at strengthening of public health system. We are looking at poverty levels, okay, in a community. We are looking at the eradicate, or eliminating the health disparities, right? So all these are a much larger domains. These are much larger domains than the pandemic itself, but these are certain areas which are actually causing all the problems at the grassroots level. So even to further add to this, what we usually see here is that this pandemic, COVID, okay, so we said earlier that COVID has affected rich and poor alike, okay, or then there came a time when people started saying that it has affected only people who are in cities, right? And then there was a time when we started believing that it is only affecting the elderly, and then there's a time when we start believing that more and more people are now getting affected. So we actually do not know how exactly it is progressing, but we do know one thing for sure, that there was a lot we could have done to prepare for such an event. Okay, there was a lot we could have done before the pandemic striked us. So we could have worked on our public health systems. We could have worked on strengthening our private and public partnerships, right? So all these are basically the areas where you want to work before the such a acute emergency arises. And I think it is very important when you say social determinants of health, because it is one area which is not going to give you immediate returns. Okay, so mostly whenever we talk about financing a section, so we usually think of what sort of returns this is going to give me. And every government is going to think in terms of acute returns, because they would be looking at elections in another few years. So so that is where it gets neglected. We see education getting neglected, we see poverty getting neglected, we see people not having employment, right? And see, it's not just important to create employment, it is important to create relevant employment. Okay, so if a person during COVID has lost his or her job, we are looking at opportunities to provide them the jobs which they can do, right? So it is no fun in saying that during our control of epidemic we have employed this many people in sanitary works or whatever, but then that might not be relevant, right? So to the people who lost their jobs as daily wage laborers, or while they were doing something else, they might not be that those jobs might not be relevant for them. So it is really very important that at what preparation a country has. I'm not just talking about India as a country, but what preparation does the world have as a global community to deal with such situations? And if we want to really deal with these, I think it is very important to address the social determinants of health much earlier than what we have done, or what we expect during the acute emergencies. So we need to act much earlier.
Yes, sir. Thank you, sir.
Thank you, sir. So I'm going to take the discussion. So we all know that every country in the initial phase of the pandemic have had the highest number or the maximum cases from people who comes from abroad, especially people who are being repatriated due to COVID-19. So definitely, quarantining these migrant workers was an integral part of the containment program for every country, no doubt about it. Now, especially taking the example of Kerala here, we initially started off with home quarantine, but soon realizing it's not being ineffective, we made a compulsory institutional quarantine system. So here we have a balance of difference between what home quarantine and what an institution quarantine can contribute into the containment of the disease. So when we look at that in a closer way, we see that the main two reasons by which we choose between these two type of quarantine system, one is definitely the economic stability of the country, of the government, and second one is the attitude and the social commitment of the general public. So we have the opportunity now to compare between the kind of containment system that I guess have happened in different aspects of the world. So first, I would like to request Dr. Dabota Boawari. Ma'am, please share the type of quarantine system adapted by the government of Nigeria. And if you could please explain to us what were the advantages and disadvantages, taking in accordance with the financial state of Nigeria and also the general attitude of the government, of the general public towards the pandemic. Dr. Dabota, please. Ma'am, please unmute yourself.
Yeah, thank you very much for the question. In Nigeria, there are two types of quarantine system. One is self-isolation, in which the person quarantines herself at home. Then the second one is done in the health facility. The government has also provided some quarantine places. Most of the places were not just new centers, they were either old hospitals in which they converted the ward to a quarantine center, or some state governments acquired some hotels and guest houses in which are also used as quarantine places. But due to the number of patients or number of people in quarantine, most of those places are filled up. To quarantine themselves at home for 14 days. And fair enough, a lot of Nigerians are obeying the order. When they are told to quarantine themselves, they just stay at home. They don't come and interact with others, even including their family members. Then can I get the second question you asked about the government? Moderator, can I get the second question you asked about the government? Yeah.
Yes, I'll ask it. As you said, ma'am, there are institutions provided by the government for quarantine system. But this takes a lot of financial burden to the government to support this type of institution. to provide food and support to the quarantine system, to institutions. As you said, hotels or other sort of institutions require resources, especially, monetary resources. It's a big burden to the government, especially when it comes to, states with a lot of economic burden or economic, not very economically stable. So how exactly would institutional quarantine work out in places where there is the economic stability is not very much appreciable? So what was the condition in Nigeria? Was the government able to afford this amount of burden throughout this more than 6 months now, or was the home quarantine established? That was my question.
Okay, yes, the institutional quarantine system, the government in it, and we have other non-governmental organizations that are also donating resources and funds to it, including individuals. Some of the rich people in Nigeria have donated things, either food and other supplies to the quarantine system, not just the isolation center, even for treatment also. So it has been going on. Both we have different levels of government in Nigeria, the local government, the state government, and the federal government. They are all putting hands together to help to curb the pandemic and contain it. Then for the institutional quarantine system, as I said earlier, the government acquired some hotels, and some also have donated their hotels. Some that have more than one houses, they've donated their houses. For instance, one of our former presidents donated his house, one of his houses, to be used as a quarantine system. So the government, most of the sectors of the economy have, but the health sector, more resources and funds right now is being pumped into the health sector. So I don't think it's so. Yeah, we have some challenges, but the government is trying their best, because during these periods, most of the resources have been diverted to the healthcare system, especially for containing the COVID-19 pandemic.
Thank you, ma'am. I guess it was clear.
Thank you very much.
On the same note, I would like to call Dr. Shamir sir here. Sir, I would like to ask the same question to you, but I would like to get your view on, considering a higher population density. Apart from Nigeria, we have a lot of population to take care of, and what we have seen here in Kerala is that we're switching in between, from home quarantine, then to institutional compulsory institutional quarantine, and then moving again back, the government advocating this sort of room quarantine or, this home quarantine system. So what exactly do you think is, when it comes to a highly populated area, how exactly do you think this system work, and what is the contribution these two type of containment system will have on containing the pandemic? Sir, please. I guess the question is clear, sir.
Okay. Thank you, Nitin. And I'm Dr. Shamir, representing Calicut Medical College from Kerala, part of India. And regarding the quarantine and all the containment strategies, first of all, we have to think in a broader way. What are we aiming at? That is the first question. So are we believing that we will be able to contain this infection as a whole, or are we believing in such a state that we will be able to get rid of this virus as a whole on a long-term basis? What are we aiming at? That is the first question. So all these containment strategies have a role. If we plan something like, okay, if we prolong this infection for 1 or 2 months, then this virus is going to get lost and we will be saved from the virus. If that is our belief, then there is a role for all these things. But what we really aimed at, we were actually learning through all these months. We were learning about the virus. We were in the learning process. We didn't know actually in the months of February or March. We didn't know what is going to happen. Whether this virus is going to live with us, whether the virus is going to kill everyone, or whether we are adapting to the virus and we are going to start living with corona. That was the first question which we faced in the months of February or March. So that time we needed time. So we wanted to prolong this somehow. We didn't want to have the peak of the infection, because we were very sure that we will not be able to withstand such a massive number of infection with a massive number of hospitalization and such large number of ICU care. A state like Kerala or a country like India cannot afford such a large number of patients as a whole. That was the first thought which came into our own mind or our strategy makers' mind, including our government. So what we tried is we wanted to prolong the infection as a whole. We wanted to prolong the peak and what is called the flattening of the peak. So initial strategies were to contain. We knew that the virus is coming from outside because we didn't have an inherent our own virus here. So the initial virus, the source was from China or then the Middle East countries. We had a lot of people coming back from there. So the initial our aim was to contain this virus within themselves so that a massive number of infection doesn't occur in our own state. So it doesn't go to the what is called the local spread. So we wanted to prevent the local spread and then the community spread. That was the first aim. So we started with a containing strategy so that we have to quarantine every person who is coming from outside India. So that time the government or our policy makers made a decision to give them institutional quarantine. So everyone was given an institutional quarantine initially. So that time we could afford it because the number of people coming from there was minimum and we had enough resources also. But as the time went on, we had a period of lockdown in between. So we have almost a period where the virus was almost contained. Then the large number of people started coming back from other countries and gradually the local spread started occurring. So at that period, almost we had spent 2 or 3 months in lockdown also. So we had almost depleted almost all our resources and it was inevitable. We knew that, we learned that this virus is going to be here for long time and the infection is inevitable. So we cannot, a country or a state like Kerala or India cannot afford such a containment system containing quarantining all these people coming from outside and continuing a lockdown, because we are going to suffer in all other parts of our life, including our economic collapse. So that is a place where we started a rethinking and we started planning in something a different way. So gradually we removed the institutional quarantine and we started home quarantine. And slowly we took away the lockdown plans and we started gradually opening up our systems so that the economy can get back. But at the same time, I would like to stress that those periods we had a very good, something like a very good strategy, because all these people who were having a low income, like migrant laborers or who are dependent on the daily wages, etc., were taken care of in such a good manner that we could produce, we could supply food. We had systems like community kitchen where the government and the local authorities could prepare food and supply them. There were systems where the food grains were given free of cost. So during the beginning 1 or 2 months, we had a very fine system of taking care of almost all the people. And as the time went on, we started gradually releasing our restrictions, and gradually, I think now we are almost in the community spread, and we have realized that we cannot go on with those strict containment measures. So naturally, I think that should be the way in any place, because as we are in a learning process, gradually we'll have to change our strategies. Every day we will have to learn more and more, and we have to think about the virus every day, and we have to change our plans accordingly. That is what happened in our state also.
Yeah, thank you, sir. I guess the topic has been explained well by both Dr. Dabota and by Dr. Shamir. On the same note, Dr. Abdul Nasser, sir, as we have discussed this on the aspect of more of a developing countries, I would like to know what was the condition in United Kingdom as far as the containment system was concerned, especially being a much less populated as well as on a position of higher economic stability. What exactly was the plan and how exactly did it affect the containment system in the United States, sir? And also, if you could, I guess this question should be answered by some of the administrators, but if you have some point on this, how exactly should we allocate resources amidst the pandemic? I guess the questions are clear, sir.
Yeah, it's very clear, and thank you very much for that question, and it's easy to answer. Basically, as you mentioned, UK is an affluent country, and people are a um, what do you call is they are well mannered, and they will, if the government makes a policy, they are very keen to follow that policy, and they got their own way of adapting the system. So what we have done in the beginning is mainly the first case started coming from Italy. When Italy has started having the problems, we started planning things. So initially, as we say, we didn't have the institutionalized quarantine system. Basically, what the government advised is shield the people who are very prone for infection and mortality, high mortality group. So they all received the letters from the government. They don't have to go for work. The government will be paying for them, and they can stay inside. They can lead on their life without mixing with the other members of the family who moves around, youngsters and all. Now, coming back, the next step what the government has taken is, if anyone has got symptoms or signs of COVID at initial stages, like early April and last March, there was not enough test kits available in UK. So anyone in the family develops any symptoms, they have to shield. I mean, they have to stay home, including all the members of the family. So no one was going out. And neighbors, colleagues, people who will look after that, will help them to get the food and the daily materials and all. They will supply them without having direct contact. So that was the system which we adapted in UK at the initial stages. So there is an economic impact on these things. People staying at home itself will affect the economy. But there's countries with a bit of reserve. This is affordable. So if any kid develops any signs and symptoms of the COVID, then whole family is isolated. So none of the neighbor will go or mix with them. Then later stage, the whole country went into lockdown. So most of the quarantine happened in their own home, which is in a bit much better than the system we have adopted in Kerala or India or in Africa. And it worked also, because when it came to the total lockdown, our numbers came down rapidly. So initially there was a bit of lax for total lockdown, but quarantine was happening very well. And another thing, the closing the borders took a bit more late. It was a bit late step to close the borders. That's one of the thing affects any region, because it's difficult in this modern world where this universal economy, universal things, it's very difficult to close the borders, especially European borders and American borders and things like that. So that had the impact on the number of cases. But as you said, you don't have to institutionalize people. You can, if there is people are well ready to follow the rules and regulations, you can do this at a home quarantine way. So that's the way the UK has tackled the situation. Is that almost clear?
Yes, sir. Yes, sir. So that's the basic point. The attitude and the social commitment of the people, I guess, does matter when it comes there. And here we have a lot of population, I guess, which is a big challenge for each and every one of us. And that, I guess, was the thing. Thank you so much.
You're welcome.
Thank you, sir. I would like to now shift from the normal protocol that we were about to follow, because we have a lot of interesting questions from our delegate Ephraim. So he was asking about the management of resources accordingly in the midst of the pandemic. So we have a lot of different answers, because there was a lot of healthcare needs that need to be looked after, which is more important, or more, which is having more priority than this viral infection. So I would want to keep an open discussion between the guests to voice their opinions on that. So
I would like to say that the allocation of resources depends on the countries. Each country has its own health challenges. For instance, in Nigeria, we are fighting most of the communicable illnesses and infections like malaria. Also, there's high incidence and prevalence of the NCDs, the non-communicable disease. And I work in the emergency room. We've noticed recently that most of the people with controlled diabetes are coming down with the COVID infection. We don't really know why, because we don't have much resources to go into detailed researches to find out why that is occurring. But since most of the problem, that is what the government is trying to fight. So I feel generally that most other illnesses will be suffering. There's nothing much anybody can do about it. Although malaria, they've been, for instance, in Nigeria, some of the malaria drugs are given free for children and also pregnant women that attend go to public health facility. Most of them get malaria treatment free. For other drugs, they have to pay. So I think every government and what they look at the healthcare system, that's just what I'll say. I don't know about other countries. I think I'll know what is happening in India, UK, and other parts of the world.
I'd like to add to what Devota has already said. And I completely agree with her when she says that it has to be country specific when it comes to allocation of resources. If we look at India, and we need to understand that India is one country which has sort of a triple burden of disease as of now, if we consider current pandemic. So we are looking at already existing burden of communicable diseases, as well as the rising burden of non-communicable diseases, and now an additional burden of the emerging diseases, right? So when you look at the situation of India as of now, can we actually afford to neglect other essential services? So can we actually afford to compromise on the maternal and child health related services? Can we actually afford to the rising burden of mental illnesses? Can we actually afford to not take care of the needs of the elderly during this pandemic? So it actually becomes very important, country to country, like what problems we are dealing with as of now as a country. And so these are some acute problems, but at the same time we have like a lot of burden due to other important conditions and diseases which actually we cannot ignore. So I think if it comes to resource allocation and priority setting, I would say that it is very important to bring in the the noble four concepts of bioethics. So we usually talk about justice there. We usually talk about so justice in terms of equality, fair opportunity for everyone. We talk about beneficence of people. We talk about non-maleficence and autonomy. So I think these principles can help us allocate our resources apart from the more technical technical ways where we are trying to look at the cost effectiveness, cost benefit analysis, what intervention will give us better returns in terms of health outcomes. That is there, but at the same time we need to understand that it is not all about the numbers. Okay, it is also about that that other aspect of the art of medicine, art of taking care of the people of the country. So I think that's really important.
thank you, sir. Does any of the other delegates want to add on to this?
I just wanted to add some point about this. I mean, even if you have all the resources and money and all, that doesn't mean everything will be moved in a proper way, because we had few makeshift hospitals made in London and other parts of the UK. But they didn't think how we are going to stop them, how we are going to run this, how we are going to do the critical incidents, how we are going to manage. So money doesn't make a lot of difference. You need planning people, you need advanced planning, all these things. So money and resource is one part of the whole package, basically. So everybody has to think in the same way, everybody has to have a uniform plans. So that's also we have to consider when you make these sort of big pandemic, how to deal with the pandemic and how to deal with these cases. So I've seen a lot of confusions and problems with proper channeling thing without doing the proper channeling. You know what I mean? It's difficult. It's not easy when it comes into a pandemic situation and to deal with it. And it doesn't occur within 1 week or 2 weeks. Things go smoothly. That's one thing I had to add. Yeah.
Yes, sir, very true.
Yeah,
does anyone else want to- yeah. Yes, sir. Shamir, sir, go on.
Yeah, I would like to add something also, because when we talk about India, India itself should be considered as a collection of so many countries, because many things which is told by Dr. Shiv Joshi may not be exactly that what is happening in our state called Kerala, because we have entirely different social setting, and even the determinants of health are entirely different in different states of India. And as far as, because somebody was specifically asking about other diseases, other communicable diseases, etc. In Kerala, the biggest advantage, when we consider the fight against this virus, every country or every state, we are balancing our strength and our weakness. What is the biggest strength and what is the biggest weakness of each state or country? And as far as our Kerala is concerned, our biggest strength was our the properly placed public health system, because every person in the rural village, in the remote place of Kerala, had a connection with the health sector, and there is a person, something called a medical officer, and below him there are a lot of health workers, including Anganwadi workers, Asha workers. There are so many people who work on a daily wage basis, who have a continuous communication with the local people. So there is that has happened so many years before. It's not something that is contributed by our COVID virus. It has been there for years, and that was the system which helped us in this era of COVID, because when this started, we had a continuous monitoring of all these people, and those healthcare workers, they were not only monitoring the COVID symptoms but the other diseases also. So when we consider all other communicable diseases like malaria or dengue or whatever it may be, so we didn't have to suffer much in that aspect. Our main problem was the resources for distribution of resources for other purposes, like other our maintaining of our economy, other unrelated to health, their jobs and their wages. Those things had a big suffering during this period.
Thank you, sir. So I would like to thank Efrain for posting the question in the comment section. Now moving back to the protocol a bit. Now my next question is a typical cliche question, that is non-COVID patients in the COVID era. So I would like to ask Isabel to speak on it. So Isabel, can you please voice your opinions and views on this, about how life is going to be different if this doesn't go away, and how do you feel the current situation and how people are dealing with it right now? Isabel, am I audible? Ma'am, can you please?
Yes, can you just repeat the question?
Yeah, it's a very cliche question, but the topic is non-COVID patients in the COVID era. I mean, you are an emerging medical field professional, so what do you feel about this topic?
Non-COVID patients, yeah. The way I interpret that question is, I do think we are neglecting so much of the medical issues that were present around the world, and obviously a viral pandemic has become a priority, but especially here in the United States, the health inequities and the disparities in terms of health access and health outcomes are still very much present, and more than present, have been really increased. I think this is not specific to the US, but the pandemic has definitely shined a light on a lot of the disparities, which run along race lines, which run along class lines, poverty lines, as well as, geographic lines, somebody's zip code. So I think it's easy for us to neglect that, but I think what connects all of this, whether they're COVID patients or the health issues that existed prior, is the lack of public health infrastructure in our country. We've had a really decentralized response. We have leaders who neglect complete warning signs and leave things really up to more local authorities, and that it hasn't been a sufficient response. That's been clear. So I think, as one of the most wealthy countries without a universal healthcare system, without a public healthcare system like many other quote unquote developed nations do, it's become so clear to me, at least, that should be priority number one, to really develop our public health infrastructure.
Yes, ma'am. Thank you for your response. Now I would like to ask the same question to Efrain, sir. So what is your thoughts on this? I would like to listen to your thoughts as well. So can you hear me?
Yes. Hello.
Okay. Please carry on, sir.
Yes. Hello. Can you kindly repeat the question?
So the question was same. It is the topic is known COVID patients in COVID era. What is your opinion on that? And can you elaborate on that topic? What do you feel? What do you understand from that?
Well, I think this we have been discussing this from the very beginning in terms of allocating resources and identifying the needs of the population. Unfortunately, I guess, and it's very unfortunate that we learn about our weaknesses, our gaps by exposing those at the bottom. Normally, the ones who suffer the most are the poor ones, and it's like a natural experiment. We learn from them, yet we don't change anything that we actually learn. I was in terms of answering your question. I would like to pose a question like, should we trust the past when planning for the future? Because obviously, we haven't been doing a great job.
Yes, true.
So I think that is answered. In the beginning of this pandemic, in the early April, something which shook us all was when Asia's biggest slum in Dharavi of Mumbai was affected with the pandemic. We saw clusters of cases coming up from Dharavi with a population density of 3.6 lakh per million square kilometer. So packed on the narrow lanes and stocked in cluster spaces, Dharavi, which was one of the COVID-19 hotspots in India's financial capital, has now come up to become a model that is being lauded by many to curb the spread of the virus. So I'm sure our audience would like to know more about the Dharavi model. What was it? It was intensive testing or contact tracing or isolation protocol or whatever it was. What was the science behind that? And I would like to add on the thing that it is heard that Philippine government is taking up the Dharavi model for containment of the virus there. So I think Dr. Shivjoshi can answer this.
Thank you, Kavya. I think Dharavi, if we talk about Dharavi slum in Mumbai, it has actually emerged as a global role model for containing the spread of novel coronavirus. And I am making this statement in the backdrop of the comments made by the Director General of WHO, Dr. Tedros, who actually lauded the effective containment strategy employed in the slums of Dharavi. So let me set the context for all of us here, because we are coming from different places. So Dharavi is Asia's largest slum and is located in the city of Mumbai, which is within the state of Maharashtra, from where I come in. And it spreads to a little over 600 hectares. That is around, let me say, 12 times the size of the Vatican City, or it's around 3 times the size of Monaco in Western Europe. So it consists of densely packed, we are looking at single as well as multi-storied buildings, and it is a home to around 3.6 lakh per square kilometer, 3.6 lakh people residing per square kilometer as mentioned by Kavya. That is just a little less than 1 million people living per square mile, just for reference. So given the poor sanitation and the overall socio-political cultural environment that we see in Dharavi, it obviously became the hotspot for COVID-19, no doubt in that. So the first case of COVID-19 was confirmed in Dharavi on I think 1st of April, if I'm not wrong. It was 1st of April 2020 when we detected the first case in Dharavi, and in a period of less than 30 days, there were close to 500 cases. Okay, so can you imagine that? It was not a surprise given the context earlier, but it's still overwhelmingly high number of cases in a very short amount of time. So we were looking at a doubling period of just 18 days. Okay, so most of you can do the math now. In the month of May, the cases rose to over 1,200 with around 60 deaths, and the situation was really grim. And then we look at June, and there was not a single death in Dharavi. Okay, so if we look at April, we were looking at lots of deaths, and we already had around 60 deaths in the month of May. And now when we come in month of June, though there are still new cases happening, but there was not a single death in Dharavi in June. So we were looking at a doubling time of 78 days in June versus the 18 days in April. So of course, it was something that was previously thought impossible. So how basically this happened? So it was a lot of a lot of work. The government of Maharashtra and the municipal corporation there is called Brihan Mumbai. So Brihan Mumbai Municipal Corporation, with the help of course, the healthcare workforce, they effectively were able to bring down the number of cases in Dharavi. And this is the reason why actually it is important to look at Dharavi model to control the COVID pandemic. As Kavya has also told us that government of Philippines has already adopted this model, and I'm sure many more places might actually be adopting this. Our own country is trying to adopt this. So how did they do it, right? How did they do it? That's the million-dollar question, right? That too in an area where physical or social distancing measures are next to impossible to implement, right? So this model had multiple solidly implemented components, all right? Strict containment measures were enforced with three important areas of focus, which basically included an effective containment strategy, conducting comprehensive testing, as well as ensuring uninterrupted supply of goods and essential supplies to the community that is residing in Dharavi. So the model of 4Ts was actually adopted. So someone was actually trying to say whether it was the tracing or the tracking or the testing, but it was actually all of those. So we had a model in Dharavi which was working on all the 4Ts. We were tracing maximum number of people, we were tracking all of them who were positive, we were testing as many as possible, and we were treating those who were affected. All right. What was more important to know is that all the residents of Dharavi were screened for symptoms for early detection, which was basically the first step how we could control this pandemic in Dharavi. So a little less than around 50,000 people were covered door to door for symptoms with the help of with the help of the staff, the healthcare staff. Over 3,000 people were checked using, the fever camps. A lot of people were covered using the senior citizen surveys, while around 2 lakh, 1.5 to 2 lakh people were covered using the private clinics. Okay, so a lot of efforts went into that. All the potential contacts of COVID diagnosed patients, all the patients were actually, the contacts of these patients were shifted to quarantine centers. And what was also done, as I think our honorable panelists from UK also mentioned about makeshift facilities, right? So a similar approach was also there when we talk about the Dharavi model. The nearest sports complex, that was the Rajiv Gandhi Sports Complex, was converted into a COVID care center with 300 beds to take care of all the asymptomatic and the mild cases of COVID-19, while the COVID designated hospitals took care of the more severe cases. Nearby schools as well as marriage halls and libraries were also then converted to makeshift COVID facilities. I think all this coordinated effort has resulted in keeping check in the pandemic in Dharavi, with only a little over 80 deaths out of the total, 4,200 deaths that we are looking at in Mumbai. And what was earlier considered to be a COVID hotspot now turned out to be an excellent model for COVID control uh, for the entire world to learn from. And that is how I see the Dharavi model for COVID-19. Yeah.
Thank you, sir. Now, I would like to bring your attention to a less talked about model. Well, medias are talking about it less only. That is a Taiwan model. Well, to be honest, Taiwan is not far away from China. It's just around less than 150 kilometers away from the coast of China. But they have effectively contained the virus since its outbreak. Well, totally, according to the information I got right now, it's 487 cases who have been recorded, out of which 450 have been already cured and 7 deaths were there, and rest of them are under treatment. Well, when all other countries, especially China, panicked, they could do something great and control the cases to a very great extent. So I would like to pose this question to Efrain, who is currently in Taiwan. One question is, Taiwan was one of the places that was hit in a really bad way during the SARS pandemic in 2013. Where WHO has not put it under the list of highly adversely affected because around 700 patients were only there according to them. But I do feel that here the earlier points that we talked about, the social determinants of health and the importance of the cooperation between the public and private sector for implementing a very fast and strong response to a pandemic has been taken care. So, Efrain, sir, to you, can you speak a bit more about the Taiwan model?
Right. First, I must mention that I'm very honored to be representing on behalf of Taiwan. I'm originally from Belize. So I'm going to speak about what I know about Taiwan and try to answer your question to the best of my ability. I did once order and I prepare a presentation to kind of make it more visually appealing. Just give me a minute.
Okay.
That's really great, sir. Thank you.
Can you guys see the PowerPoint presentation? Yes?
Yes, we can see it, sir.
Yes, yes, sir.
All right, so first I must mention that before the WHO declared COVID-19 as a public health agency of international concern, Taiwan had already started implementing trade and travel restrictions or measures along with other countries. Officially, Taiwan closed its borders on March 19th. So if there are so many topics and so many areas that I can touch, but I'm going to focus on three main and key aspects. The first one is the digital healthcare system. The second one would be political engagement. And the third one would be community engagement. And as you rightfully mentioned, the success of Taiwan is not just pure luck or chance. There is some painful memories going back to the 2003 SARS outbreak, and that's where most of the lessons come from. To give you context, based on SARS outbreak, Taiwan was hit very hard actually. Taiwan had 364 confirmed cases and 73 deaths. That's like 4.3% and 10% cases and deaths respectively. So Taiwan did learn a great lesson during 2003 SARS outbreak, and that's where a lot of changes happened. It took many serious steps. The first one is a digital healthcare system. This system is digital, which allows Taiwanese to monitor remotely patients, their status, and they can exchange information. Doctors can actually exchange information with health officials. And a very good example of the collaboration that happened recently is the National Health Insurance Administration and the National Immigration Agency. What they did is that they combined their databases. They joined their databases and they combined the medical and the travel history so that they can tackle or they can identify those patients that are at risk. And then the communication went back and forth. In terms of the political engagement, It happened right after the SARS outbreak in 2003. It started in 2004. What the government did is some sort of reorganization. They enacted laws, they formulated policies, and they established institutions. One of the very important and key institution is the Central Epidemic of Command Center. And I would like to shed some light on this center. Basically, the function of the center is to coordinate. Of course, coordination is key during this pandemic. So they coordinate across different government ministries and agencies, and they also coordinate between government and businesses. A very good example of the coordination between government ministries and agencies is the one that I mentioned between the Immigration Agency and the Health Administration. And then on the other side, you're going to see that there is also coordination going on in terms of the big data analytics. They collect data, they analyze it, and try to come up with uh, reports, and those reports guided decisions being made by the policymakers. And then there's also testing, quarantine, and contact tracing. In terms of quarantine, the CECC plays a crucial role. They partner, they work along with police agencies, they work along with telecom companies, especially for quarantine, so that they can enforce the quarantine via mobile phone tracking or tracing. Uh, Something that surprised me a lot and that it's very humbling is that actually the ones on the front line, the CECC, they led by example. So their leadership is very, very strong. I clearly can remember one time when the public, they were kind of refusing to use pink face mask. So what the CECC did is that they actually the following day they wear all of the guys, all of the male participants, they wear pink face masks. So that sent a very strong message to the public that we are in this together. So their leadership is strong, their coordination is strong. In addition to the institution that they established and that I just mentioned, they also had face mask production and distribution. The government took control over that. They subsidized companies to buy equipment with one condition, and the condition was that they were going to be selling the mask to the government so that the government can ration the distribution. Then the government went further and they developed welfare schemes, helping quarantine and isolated patients financially and medically. They also announced also a very strong response was the political agenda against China. What this actually did is that it propagated some sort of empowerment. The people gave had some nationalistic feelings, like we have to win China, we're going to do better than China. So in reality, it helped Taiwan to fight the COVID-19 pandemic. And then there was also strong awareness broadcast that the CECC had daily briefings. Now it's every week, but still there since the case are decreasing. And then the last point that I have is the V Taiwan, which is actually a virtual democracy platform where the public can communicate with the government. It's like a platform where we can discuss and try to reach policy solutions. Please stop me if I'm going too quick. I'm just trying to date in the best interest of time. And then the third approach or the third aspect that I would like to talk about is there was a lot of fear. It goes back to the 2003 SARS outbreak. People, they feared another outbreak like the SARS outbreak. So what they did is they took recommendations, they followed the guidelines and the protocols without any much hesitation. And then there is a key point I need to mention is the trust. The government has all along been accountable. They have been transparent and they have been reporting back to the public and seeking their advice, seeking their contribution. And that trust that has become even stronger. Hence why the people and the public actually engage and they follow the recommendations from the government. And lastly, we have a very community-oriented mentality unlike other countries which are very segregated, separated, or individualistic. Taiwanese, we the Taiwanese community, what happens here is that we try to sacrifice our own pleasures in the best interest of the community. And lastly, but not least, is the education, of course. Taiwan is a country with a high literacy rate, so the messages that are being given by the government is easily followed and can be easily implemented because the Taiwanese are very well educated and they are health conscious. All right, thank you.
Thank you, sir. Um, Guess before moving on to the clinical lessons, I guess we need to discuss this. With the pandemic challenging the modern scientific medicine at its every possible level, with the world currently looking for any sort of possibility for help, we can see a big boon in rise of demand and use of alternate medicines or traditional form of medicine. So, I would like to request Dr. Alejandro to please join me here and share his view, especially on the fact that we all know that use of traditional medicine increases when the scientific temper of a society kind of decreases. I would like to know what is the effect, what are the effect, I guess, when the public kind of use or start using traditional medicine with regard to the pandemic, and also is there any evidence of any sort of positive study report stating a positive outcome by using traditional medicine all around the world? What is your view on that, sir? I guess the question is clear. Dr. Alejandro, please unmute yourself.
Yeah, sure. Well, I think that the pandemic did not change the role of around traditional medicine. I will say it actually it show us that it remain important. The key for us is as scientists to either provide the scientific support of how it actually can work, or just work with the communities and try not to harm their cultural and their traditions. So yes, we have some statements around traditional medicine working for COVID-19, either in China, even in Latin America, even in my family. So we are lacking a lot of evidence on that. For sure, what we try to do, especially, I think Dr. I forgot, I cannot pronounce the name, who's also doing family medicine, can tell that the idea is to work together with the culture and traditions of the people so we can actually improve their health. So basically what we are doing right now is that if they want to perform any traditional medicine procedures, as far as they are not harmful, as far as they are not going against the medical advice, well, you can perform it. You can be feel free to do it. But that's when we have to come in and actually know the traditions and cultures around people. So doctors, especially those who tend to live in cities and then go to the communities, they don't know how it works. So they might either just say, okay, do it, and they don't know it can be hurtful, or they just say, don't do it because it's not science, and then you come into conflict with people. So the invitation here for everybody is to actually know the community you're working on, to know the traditions, the culture, how it affects people, and if you want to provide some advice how you can do it properly, because that's another thing. You can know how to do it, but you can might not know how to say it. So communities, especially around traditional medicine and cultural aspects, might be really sensitive around it. So also the final invitation for this will be to you to elaborate some scientific performances around traditional medicine, not only for COVID-19, but for other kind of evidence that we can build for them.
Thank you, sir. On the same note, if I could have Dr. Dabota Buawari. Ma'am, can you please, share your idea or your share of view on the same topic, use of role of traditional medicine, and we all know this. People have and increased tendency of using traditional medicine? How exactly do you see it, and how exactly do you think it will affect the public, be it positive or a negative way, amidst this pandemic? Dr. Dabota, ma'am, please.
I'm afraid Dabota was not in the group when you posed the question.
Okay.
Hello, ma'am, can you?
Dr. Dabota? Dr. Dabota, can you unmute yourself?
Yes.
Okay.
Ma'am,
Please, can I get
the
a
question was, ma'am, yeah, I'll repeat the question for you, ma'am. Okay, we are going through a pandemic which is challenging the modern scientific medicine in every way we can. So there is an increased use of traditional medicine, people moving on to alternate medical, system in order to find some sort of help. So how exactly, in your view, do you think that the role of, alternate or traditional medicine will affect the society in future? And also, do you have any sort of, effect, whether it is positive or negative effect that this particular pandemic has caused in use of this traditional medicine? I would like to get your view on the topic. Ma'am, I guess the question is clear.
Yes, the pandemic has a lot of impacts on the society and also on healthcare workers. First, in healthcare workers, everyone is faced with a shortage of resources, especially PPEs, personal protective equipment. Generally, there is shortage. For instance, in Nigeria, we have shortage to the extent that now even the face mask has to be recycled. Most healthcare workers, even those working at the isolation center, have to recycle their face mask because they are in short supply, including the N95. Some hospitals are providing, some healthcare workers have to get for themselves because everyone have to protect themselves, because after work, we're all going back home and no one wants to take an infection home. Also, besides the resources, it have an impact on the psychology and the emotional well-being of the workers. This extends not just for the healthcare workers, even the general populace. If you check on the internet right now, there are a lot of studies and literature that is going on the psychological impact of COVID-19. And after this conference, I will urge every one of us to conduct, even if it's a small research, wherever we are working. For instance, I'm a leader of the Young Doctors Forum Research Group of the medical women's in Nigeria. And one of the researches we are conducting is on the psychological impact of COVID-19 pandemic on medical doctors. So it has a lot because it has affected the psychological impact of everyone, emotionally and mentally. For the general populace, as even before, as we said earlier, some people are losing their job. So it also impacts on the economic and financial aspect of everyone, but especially those that have lost their jobs, because people are finding it difficult to feed. Now they are losing their jobs, so they don't have a source of livelihood. There are a lot of other impacts that this pandemic, there is no part sector of the economy that is not affected, not just, then going back to an earlier question that was directed to one of the guests, that the COVID-19 pandemic in non-COVID patients. During the lockdown, people could not be able to access their drugs. For instance, patients that were diabetic and hypertensive, most of them had a difficulty in accessing their drugs because we say stay at home, and most people in Nigeria use public transport system. So during the pandemic, the public transportation were banned. They were not operating, so they can't come to the hospital to get their drugs. So many other impacts, for even including surgeries. For now in Nigeria, most government hospitals, including the private hospitals, have suspended elective surgeries. It's only emergency surgery that is being done in most hospitals, not none. So patients that have been scheduled for elective surgery have to wait. No one knows when it will be lifted. So I think there are a lot of impacts they have. If we go on and on, it will be a whole day talking about the impact. Thank you.
Regarding the traditional medicine, I think Alejandro has said it correctly, that we should, at this point, your faith promotes. But when it is a matter of public health, you need to have a scientific temper dealing with it. Yet, Dr. Dabota has pointed out a very important thing. in our society, we are currently on a position that we are ready to believe that even the sound waves from plates will kill corona, because that is the kind of fear that people are having right now. I think Dr. Shiv Joshi can take this question. The fear that has been encountered by the patients, by the people, sorry, not the patients. Of course, patients are also having this fear. And yes, there are a lot of suicide cases that are happening in the past few months. Also, the patients, the people who are COVID positive. And as you're a representative of IMA as well, IMA had an opinion that there is no need of publicly pointing out the cases to the public, because that is not needed at this point. That will only generate a fear to the patient. But a lot of doctors had opinion against it. I think Shiv Joshi can take from here. Sir, unmute.
Thank you, Kavya, for that question. And I believe that it is a very genuine concern when it comes to corona pandemic, that it is more of a fear pandemic. Okay, so we need to understand that the disease itself is not that big of a problem when we compare it to the fear that people have for this disease. So if we look at our discussion today in this panel discussion, we all of us have spoken, and we all know and agree on the part for this pandemic where it is a very easily preventable disease. So if you follow the preventive measures, if you refrain from any contact with or you maintain the distance, you maintain the social distance, if you're wearing your mask, so if you're basically doing all of these, it is very less likely to it is very less likely to spread. I myself have been working in the quarantine committee of my own institute, and recently I was also part of the zero surveillance that happened for our district. What I came to know through interacting with people, general population, by interacting with people who were part of the containment zones, and I also interacted with some people who were high risk groups. So by high risk groups, I mean police personnel, I mean the healthcare workers. And when we actually go and talk to these people who are actually serving in the field, people like us, doctors, nurses, it is really important to understand that a lot of this fear pandemic, the source of a lot of this fear pandemic is coming from the people who are working in health. So that is something that is concerning. So when you say that some of the doctors point out, and some of the doctors were of the opinion that it is not right to say that it is just a fear pandemic and not. So I'm not saying that it is okay to not understand the magnitude of the problem that we have for COVID, but at the same time, it is very important to understand that the deaths that are happening in COVID is nothing as compared to the deaths we have in our country due to tuberculosis. Okay, it is nothing. It is nothing. It is not even a speck. Okay, when it comes to HIV, if you look at many other countries, the deaths that we are seeing due to HIV, it's a lot more when it comes to if you compare it with what is happening in COVID. So is there really a need to create this panic? That is the question one. Second, many people have tried to justify this fear pandemic by saying that because there is this fear among the people are taking all the preventive measures, wearing their mask and everything. But when I look at it as a as a civilization, as humanity, as a society that is scientifically advanced, do we really need to create this fear just in order to make people more compliant? And if this is what is still needed, then is it right to actually call our civilizations as advanced civilizations? So there is this dichotomy, and there would be debate on this. But then if you ask for my personal view, I would always say that so we actually conducted a study on this. So we wanted to find out what are the sources of information. Okay, what are the sources of information for people who are visiting our outpatient departments? So from where do they get all this news regarding COVID? All right, and it was really it was not surprising, but it was fascinating to see that it was usually the news channels, media. Next to those were their relatives, and it was around at a sixth or the seventh place where it came to a doctor. All right. So they are getting this information from a lot of other places, and it is going to generate fear. So wherever there is uncertainty, things that you don't understand, it is going to cause anxiety, it is going to cause fear, right? There's nothing, I mean, there's nothing wrong in that. It is going to cause it. So there's nothing, nothing out of the ordinary. It is, of course, going to cause this fear. But then we also try to analyze what were the sources in which these people placed their trust. Okay, so in that doctor ranked one, right? So now what I would like to emphasize here is that as a source of information, a doctor ranks much lower, but when it comes to the confidence in information, doctor ranks much higher. So where is that gap? Is that gap coming from the health workers themselves? Is that gap coming because of the media not portraying the healthcare workers as the source of information? Right, so there are lots of issues which I think we need to address when we are trying to answer this question. But in my personal opinion, it is more of a fear pandemic. All we need to do is implement the protocols in place, take care of ourselves, take all the preventive measures, and we will defeat corona. So yeah, that's what I feel.
Yes, thank you, Shadri. Because yes, this fear is taking a lot of the toll now, and I think one important thing that we need to mention here is when we say when the mother in the house falls sick, everyone falls sick. Similarly, when the doctor falls sick, people are really worried. So I think Dr. Abdul Nasser can pitch in now, because when a doctor is getting the infection, people are really scared because they are the what they say is like doctor knows everything, like he knows how the protocol has to be done, and then still he's getting the infection. So how is that possible? So if the doctor is getting infection, we can get infection very easily. So what do you have to say about this?
I think that's an interesting and well, very very difficult question to answer. Actually, um, uh, in our intensive care unit, we started using the PPE. There was a very rigorous policy for using the PPEs from the beginning itself. So mask testing and isolation and how to put the whole PPE. This was basically it took about 1 month to train all the staff and members of the hospital how to use the PPE, and it was very rigorous procedure. Actually, it worked very well. And each and every member working in the hospital had the training, had the mask testing, had all this training. Still, I had the infection. The reason for that is when we approach the patients, when I go to the intensive care unit, yes, I'm in a full PPE and all. But when I attend the meetings and all, my junior colleagues are they might not have taken this very seriously with the social distancing and sitting in the same room, having the handover in intensive care unit or in the ward. And so we are all a human being. We are not um, different species. We are all human being. We are susceptible for infection. This problem, the doctors getting infection and the public is getting panicked, is not an issue in developed countries, because they got all this knowledge and things. But in remote places like India, this is a different way, because you will be isolated, you will be treated as a separate thing, and you may be suffering because you have doctors in the family and they are bringing the infection from the hospital to the home. I think it's a matter of people having the knowledge and developing the what you call is social network and things. Then the people has to learn quite a lot about this infection. No one is immune for the infection. That's the thing message you have to give to the public. Then only you won't be isolated from the public. And public should lose the fear that infection is definitely going to kill some people. It's as Dr. Shiv Joshi was saying, it's not a very massively killing disease compared to Nipah or Ebola, because if that has happened, it would have contained in that region and it would have stopped. This is a very mortality is, the number of people affected is high. At the same time, mortality is very, very low. So you need to give that message to everyone, and the people has to develop a bit more confidence in the doctors. Doctors are not immune for anything. We are all human beings. That's the main message we have to convey everyone. And doctors has to do the precautions. And doctors, if he gets the infection, then he has to do all the isolation and try to not to spread this to other people. You have a responsibility to look after your patients. Same way, if you are a doctor, you should keep away from the practice and make sure you are following the local regulations and government rules. That's the main important thing here. Is that answers your question?
Yes, thank you. The coordinators can post the questions that audience have here. Well, I think I can ask to Shamir sir. There is something which we often get to hear from our teachers, that India being a place with very poor socioeconomic conditions, we are hygiene, community hygiene, not the personal hygiene. Personal hygiene is very good, we bathe twice a day, but the community hygiene is very bad. So we are kind of immune to a lot of infectious diseases. This is something I got to hear from my teachers only. So what is your take on this?
Okay, interesting question again. And is it a positive thing or a negative thing? That's the most difficult part to answer. Because we are very immune to all these infections because we get all these infections every year. And many of our elderly people die off due to all these infections. And even maybe that is the reason why we have a low mortality. That is what I believe. So I would like to start with the Dr. Shivjoshi's comment about the fear factor, because we can't compare this with tuberculosis, of course, because tuberculosis won't infect in such a massive way. That is the first disagreement I'll have to make here. And this infection, I do agree that it doesn't have such a big mortality. It's only a less, maybe if we take the infection fatality rate, maybe it's just than 1% or maybe just a 0.1% or something. But the way the virus gets hold of people in such a large number is something which we are not that familiar. In the last 25 years of our life in a medical college, we have not seen such an infection which is spreading so fast and killing so many people at a time. So that has to be respected. At the same time, the fact that we should not frighten people in such a way by giving large numbers of death and by the media, etc. All these things I also agree. And this decreased respect to virus, or the question Kavya has just raised now. I have been seeing this thing in our country, and especially in our part of the world. We don't bother about these viruses at all. All these years, every season we get viral infections, and during some seasons many of the people are sick due to fevers, and we call it like something like related to the rain. Post rain season, post monsoon season, we get a lot of infections. Many of the school students are sick, a lot of sick leaves. Even I get a lot of leave letters brought by our own Kavya, Nidin, all saying that I had fever. I don't know whether it is truth or they were just producing some false. Anyway, we get a lot of fevers in this season. That's a fact, and we were accepting everything as a part of. It's a part of our life. Just like we have a Holi or a Onam, we also have some fever celebrations going on. Every June, July, those months we get a lot of fevers. All the hospital beds are filled with fevers. And during these fever seasons, a lot of people die also. And we didn't even know what virus is causing all these things. Many a times we didn't have this type of PCR doing everywhere. every nook and corner of the country now we have the polymerase chain reaction, we have the antigen testing, we have even the genomic sequencing, everything is going on now. So this application of the technology, or what you call this investigation, everything was not taking place, and people were accepting as that is what is our health is. So we were not even trying to prevent such an infection. So it can be closely related to our what you call this hygiene practices. We used to spit everywhere. I don't know whether I can talk all this in front of our delegates from other countries. So our people, our manners, or our hygiene always had when we compare with all these developed countries like Europe or US, everywhere, and we had a very poor concern for all these things. We used to travel everywhere with infections. We used to travel coughing in the public bus, train, everywhere. People used to sneeze, they used to spit. So this COVID gives something of such an insight, because we could have prevented so many things. That is what we can deal everything in a positive way. So this COVID is giving a message that maybe the viral infection which we had in the previous years also had the same mortality or same morbidity like COVID, but we couldn't realize it. So we didn't try to prevent also. If we apply all these things now, that is a personal hygiene like hand washing or mask or whatever it may be. So if we are applying some simple logics in our personal life, at least when we get sick, we can prevent a lot of infections. And that prevention of infection can even prevent deaths. Maybe that is one of the important reasons why we have a low life expectancy compared to Italy or many European countries. There the life expectancy is, I think it's more than 80, but we still have a 10 years gap. One of the important reasons for this is our infectious diseases. So we were tolerating all these viruses. Maybe that helped us to develop an immunity, but if we take it in the most positive way. But if we are taking the negative way, that made us die earlier compared to our counterparts in many of the developed countries. So we can take everything in the positive spirit. This COVID is also giving us a lot of messages. So from this, we can start learning, we can have a better life, and the next year, whether the COVID is there or not, we can apply all these messages to our own personal life, and maybe we will be able to have an infection free or something better than the previous years.
Okay, thank you, sir. That's really the point is that next time anyone catches fever, they'll surely get a mask. So that change definitely COVID has brought in us. And I have a question to Dr. Avelino sir, Alejandro Avelino sir. Sir, Alejandro sir?
Yes, I can hear you.
Yes, so there was a doubt from our audience regarding the relapse of infection on the same person getting the disease again. We see a rise in the cases in Colombia recently. So is it new COVID cases or relapse of the case in the previously infected people?
So are you asking me for the reinfection patients?
Yes, sir.
Yes,
Yes,
you have some in Colombia, okay? Yeah.
Yes, sir.
Well, as any respiratory virus, we know that they might have reinfections because they have the ability to mutate. And actually, this week we got reports from North Korea that they officially defined a patient that got reinfected as coronavirus. I think that's possible. That's something that might happen as we had with influenza in Colombia. Yet we don't have that kind of reports. We are still fighting with the first wave. But I think that that's something we have to face eventually, and maybe we are going to end up similarity with like influenza virus, that every year you have to get a shot, especially if you are in the risk group and also if you are a health worker. But something that is clear for us is that even if we have reinfections, it's not as frequent as something that can be worried for us. So we just got one patient from over 5 million that got COVID-19. So let's face it, it's not that bad. Maybe this patient is not going to be that risky. So eventually, in a couple of years, we will have more patients, but we have to focus on what we have right now. And I think maybe that will create even more fear in the communities. If you tell them that just one patient got reinfected, they will believe that they might get as well reinfected. I think that the way that we are managing scientific evidence is just creating more fear in the community, and that's a good example of it.
Hello, Alan.
Yeah, that was it.
Yes. Thank you, sir. Thank you, sir. Alan can take over, I think.
Okay, thank you, Kavya. I think I'm going to take a question from the audience right now. I'm going to ask it like an open discussion right now. I don't think how much it is valid of now, but I do believe this question has a sort of relevance. Started in 2003, again in 2009, making its way, and now in 2019. Is the SARS virus evolving in its infectivity? Now, when we combine that with another question, which we're going to talk about later, if this trend goes on, and this COVID virus could evolve again and become a greater threat, maybe in the coming years, maybe 2030 or 2035, we can't tell. So, is the current situation ready to handle it? That's what the audience wants to know at the point. So anyone can, and is the SARS virus getting more infected day by day? Anyone can answer it from the delegates.
Can you repeat the question, please?
The SARS virus, right? The 2003 outbreak, SARS virus, it came up back again in 2009, and now it's a different type of virus right now, but still it's called as SARS coronavirus. So, is the SARS virus getting more and more infective in the coming ages?
Okay, great. I will just answer that. Yes and no. We know that this virus might, and this can be, well, might be losing the capacity to infect people. So we know it because of the changes that it has. You know, it began in China, then it got a big change. It mutated in Spain, and then it got mutated again in the United States and Chile, and then it got spread around. So we know it might be losing it, but we are not going to be sure or certain of it until a couple of months. We have to know that mankind always has been exposed to viruses, and now that in this example, the more you get into the jungle, the more deeper you go, the more deforestation, the more this kind of situation we have all the time, the more exposed we are going to get to viruses that already existed but have been in these areas, in these small locations for over thousands of years. So that's what happens, as you can see in most of the epidemics that we had in the mankind history. Most of them came from animals. They were zoonotic. So we are going to have even more every time, unless we change the way mankind behaves. So I will say that will be really hard. You cannot change in all the world that people stop eating animals. You cannot stop that all around the world people stop going into the jungle. That's what I want to say, that we are going to get even different viruses, even other families of SARS, as we have seen. We already have tons of families of adenovirus. We already have three big families from HIV. So the answer will be yes, we're going to face even more pandemics. Hopefully not like this one, but we will have more threats like this all the time, because we are vulnerable to the other biologic entities around mankind. So the idea here will be to learn how to actually decrease these chances of getting infected from any different kind. So if you see, if we manage to actually apply the prevention from coronavirus, we already seen that we decrease other kind of respiratory and gastrointestinal infections. So now I will think that the answer will be, if we manage to change this and the epidemiological behavior of this kind of disease is going to change, I would say the question will be, what is going to come next? Because if we don't have the regular diseases, something is going to replace it. We have to be certain about it. So I will leave that as an open question to everybody. What do you think that might be coming? And the idea will be to be as ready as possible.
Yeah. Can I answer the same question?
Of course, sir. You can.
Okay, I do agree with the speaker. We should expect not only the coronavirus, we should expect all sorts of virus, because in the initial part, in the first question itself, we were discussing about the human development, the equal distribution of resources, etc., etc., and we were discussing about our own development. So we have to understand one thing, that when we develop, naturally the other living beings also develop. It's not our right alone. So when we emerge, we should expect the emergence of all other things, like all bacteria. Bacteria become drug resistant, and more bacteria come, viruses come. That's the rule of the nature. And the second point is, when we encroach their environment, definitely they will come out. That is the second thing. So when we but we did a lot in the previous years, where we the deforestation, or all our industrialization. So whenever we try for the socialism in our development, we are trying to build new houses. We are trying to distribute our resources among ourselves. So who suffers is the animals and all other living beings on earth. So naturally, these viruses, either they come out of these forests or animals or something like that, or they mutate and they will come in a new form. That is the rule. So we have to anticipate. That's not only the matter of corona, other viruses will also come, and we will have to fight again. And this fight will go on. And till what time, we don't have the answer. But there will be a continuous war between human being and these viruses or microorganisms. That should be anticipated. And somehow we will win over it. That is what happens now. You can see how somebody was asking about the alternate medicine. So that question, I couldn't get that question that time. So what is the role of that alternate medicine again? So you can see how these things developed. When the virus came into picture during the December, January, February, there was no alternate medicine. There was only modern medicine. Nobody could even think about something giving immune booster or some prevention at that point of time, because everyone was scared. So even only the modern medicine, or who has the thorough knowledge in these viruses, could come out and declare something. So as the time went on, people started learning about the virus, so they knew the virus is not that dangerous. We can also take part in the management. So all these people came out, and they had so many what you call offers, like they can boost the immunity, they can prevent the infection, they can do this thing alone. But still we are waiting for the vaccine, isn't it? So once the vaccine comes out, every alternate medicine will go back again. The modern medicine will come to the picture, and everyone will be behind the vaccine. So that is how every time these things happen. So you can't see any other point in the history, a time in the history, where the modern science has developed so fast. Within a time of 4 or 5 months, they have evolved in such a way that you can't even believe. In December, it was just a pneumonia of unknown cause. Then came the virus. Then came the genomic structure. Then came the PCR. How to test it? How to modify the drugs? How to do the vaccine? Within 5 months, such a incorporation of our science and technology into this treatment part or managing a disease is something unbelievable. So the human development is in such a fast pace. At the same time, you have to keep in mind that the virus is also getting ready. it is also having some sort of mutations taking place, and you have to wait, you have to anticipate another episode. So the life will go on like this.
Yes, sir. Thank you, sir.
With the permission of the moderators, I'd like to make a comment on that.
Yes, sir. Please.
All right. So I totally agree with Shamir sir when he says that these infections are going to happen. Also with Alejandro, who says yes and no. There are both the sides to it. I think I would like to utilize this platform to advocate for something called as One Health. So we are talking about a lot of change in land use patterns, urbanization, globalization, where deforestation, and we have invaded into a lot of habitats of these animals, and zoonotic diseases crossing over to humans has not been it was not the case earlier, but then now today it is something that we see more often. So One Health, as most of us are already aware, I think, but just to give a brief context, when we are talking about our clinical medicine, we are talking about human beings. When we are talking about environment, air pollution, water pollution, we are talking about environmental health. And when we are talking about veterinary sciences, we are talking about animal health. But then there has to be an overlap between the three of these. The concept that we call as One Health. So that is, I think this is the right time to actually advocate for this philosophy of One Health, where we consider, that old saying of Vasudhaiva Kutumbakam. I think it holds very true when it comes to situations like this, when it is not just some people or some countries or some regions suffering from a disease, but the entire world that is suffering from it. So I would like to advocate for this concept here. Thank you.
Thank you, sir.
Yes, that is really a great point. Health for all. So it is very rightly said that once you are a student of medicine, you never stop to learn. Every new patient, every new case that comes to you is something new and different experience. So I'm sure as clinical practitioners, you must be having some new lessons that you learned from COVID. I think I can first go to Efrain. Efrain, are you here? Hello, Efrain. Okay, I think there's something wrong with it. Okay, yeah.
I'm sorry. Can you kind of repeat the question? I didn't
Yeah, actually, I was telling about the lessons that you learn from each and every new case that you encounter. So being a junior, like someone who is stepping into this medical field, how was your experience? Did you at some point think that what did I make a mistake by pitching into something like this?
Right, like you rightfully said, we never stop learning, and it's very. I think it's one of the biggest motivation because humanity and the human species, our behaviors keep changing, our genetics keep changing, lots of changes. It's very dynamic, so we're gonna have to adapt to the changes. It has been part of our history. We have the natural selection whereby animals and plants have to adapt to their environment and to the environmental pressures. So I believe that it applies here. We need to keep changing and adapting and trying to adopt solutions, try them and see if they work. It's a ongoing process. We're gonna have to keep trying and try on error. So basically, that's my response to your question. Thank you.
Thank you, Efrain. I think this question is open to all. I think Dabota can pitch in now. Dr. Dabota.
Yeah, can I get your question, please?
Yeah, it is like, what are the new lessons that you could learn from this pandemic as a clinician, as a clinical practitioner?
Okay, one of the things I've learned is to be prepared always for any patient or any condition that may just crop up, because now the COVID-19 pandemic is there, and I feel even in future we may see more of these zoonotic illnesses. We can't stop man from eating animals. We can't say everyone should be a vegetarian. So I think just to promote hygiene and good sanitation. Then from each patient, always observe universal precautions and let's see how it's going to be. I think I've learned a lot of lessons. I've learned to show empathy on all patients. Thank God I've never been infected, even though I've come in contact with few patients. But I try to show empathy on all my patients and also to practice universal precautions within all the resources that have been provided by the hospital.
Thank you, ma'am. So,
Thank you.
Dr. Shiv Joshi?
Thank you, Kavya. I think the best lesson that I learned during this pandemic is how important it is to work in tandem with the district health systems, the public health system that is already in existence. So I feel that I come from a medical college, and we have some good tie-up with the local public health system, and that was something which was very important for me during this pandemic, because being involved in contact tracing, risk assessment of these people, and actually getting them into proper either quarantine facilities, or maybe the COVID care centers or the COVID designated hospitals, managing the logistics, so it's not that easy. So from what I understand, it requires a lot of coordinated, collaborated effort when it comes to managing a pandemic like this. It is not a one-man show. It is not a one hospital show. It is not a one government show. It is like, you need everything. You need everything to help you out in managing this pandemic. So that was one important lesson of how important the relationship between the medical colleges and the public health system can be. Not just that, also how important the relationship between the public health system and the private practitioners can be during addressing any pandemic. So I think that was one important lesson I learned. Kavya, I'm done.
Okay, yeah. Efrain has got something to say. Efrain?
Right. My question is in
Yeah.
terms of like Dr. Shiv rightfully mentioned, collaboration and cooperation is crucial at this point, and hence the reason why we need to bring professionals from all walks of life and different disciplines. My question is like, is it a better choice for us to be using the experts that we have at home, or should we bring foreign aid to try to help us with the situation? Because sometimes, like all of we know, some of our countries don't have a lot of we don't have the capacity, unfortunately. So sometimes we depend on foreign countries to come in and try to help. I believe it's never too late to start building capacity, but in this situation, which one would be the best option or choice? Thank you.
All right. Efrain, do you want me to add to that?
Sure.
Yes,
my
I
my
think.
concern my concern is like probably part of the
Yeah.
answer is capacity building, but is it a good option for us to bring foreign aid at this time when all countries are actually they are segregated? They're trying to fight their own fight.
All right, all right. I think, Efrain, it's a very valid point when you talk about whether when it comes to international aid, so whether it is better to deploy local experts or go for foreign aid, because even they are suffering from the pandemic. So would that be actually feasible in terms of the finances and the other outcomes that are expected out of it? So if I understand your question well, I would like to say, Efrain, that there is these times right now, the way we are seeing it, it is something that's an acute problem, right? And when we look at the international aid during the times of crisis, we are usually looking at some disaster, a natural calamity that has occurred, at a single place, or some country that is struggling with certain health outcomes, and then you get funds from maybe USAID or UNICEF or also other funding agencies, and that's how it usually is. But when it comes to a pandemic, I think it is very important to have local experts, because local experts know the country, they know the context, they know the settings in which they are working. Above over and above this, people coming from outside, when they try to provide solutions that they think are wiser for that particular community, it might not be that welcome. Okay, so we are looking at someone from outside coming to our community who doesn't know what are the belief systems of the community, what are the social structures, what are the social constructs within the community, and how everything functions, and then giving an opinion on things doesn't just help. So funding, just funding things or international aid in terms of money, it might be a very temporary solution, even in terms of healthcare workforce or in terms of any other resource. If we talk about the WHO building blocks, if we talk about any of those resources, services, financing, if you talk about any of those components, all of those would be a very short-term solution to what we are trying to achieve here. So in my personal opinion, if we are looking for feasibility and sustainability, it is the need of the hour to do and to involve all these local level experts, and it can be, like, there is a need, there is a felt need, and there is more need to incorporate these people as stakeholders when it comes to responding to such crisis. And I also understand that you wanted to add, saying that should it be mandatory to send back those professionals who have migrated for better opportunities? I don't know if that is the part of this question. All right. So, in my opinion, I would say that it is obviously better solution, given the current scenario, to have local experts as compared to. So we need not rely on that. If you have some international aid, fine. If you don't have it, do not expect it, and even if you have it, do not rely on it. It's very important to do a local level assessment of the problems and gather the local communities to solve these problems. That's what I feel is fine. Thank you.
Thank you, sir. I guess we'll move on to the most awaited topic, I guess we have in this pandemic, that's vaccines. I guess vaccine is a word that can bring a smile, in otherwise a largely depressed world right now. With 164 vaccine trials all over the world, gives us the exact graph of the demand that vaccine, portrays right now in the minds of people. So many countries have been contributing, in different phases. Different trials are going on in different types of vaccines. Some of them are in phase 1, 2, 3. Some of them claiming they are ready to be, given out into the public. So here, what we're seeing here is actually there is an increased chasm between politics and science. So, we see more of powerful administrations, taking dangerous thoughts, driving from political goals and instant gratification. So, in this point, I would like to have Dr. Abdul Nasser, sir. So this, shortcuts in testing vaccine safety and its efficacy, wouldn't it be endangering the lives of millions? And also, doesn't it set up a state where public loses the confidence in the very idea of vaccination, which at all, if we think about it, could be detrimental as public health is concerned? So Dr. Abdul Nasser, sir, I would like to, it'd be great if you could share your view on the increased hope. First question is the increased hope that people have currently on vaccine, that this magic drug is going to take them back to the old la la land that they were enjoying. So is vaccine the final cure is the first question. And the second one is, the detrimental effect that this ineffective vaccine trials are going to cause into the public health. Dr. Abdul Nasir, sir, is the question very clear?
Yeah. It's very clear, and it's an interesting topic and interesting question. Well, it's a well formulated question. So, if you take any medical research, it has got double-edged. It's a double-edged weapon. You know that it can cause harm. At the same time, it can cause relief. Even paracetamol has got its own problems. I've seen one person taken a dose of paracetamol and came with a full-fledged anaphylaxis to the accident emergency, and we have to resuscitate. So any research going on, if I say yes, there will be a lot of people will be harmed with any trial of any medications, and we have different levels of trials. First goes into the animals, then comes to the human being, and well conducted researches in Western world there's ethical committees to protect the loss of lives. There are ethical committees for these things. And occasionally the third world countries become the scapegoat for losing lives on trial of medications and drugs. So that same thing can happen on the trial of these vaccines also. There's no way you can establish a treatment method without losing lives. It's impossible. And that's the reason the ethical committees and all has gotten. So Western world, in UK, ethical committee is very, very rigorous. They haven't given any patients any of the like hydroxychloroquine or these things, because there is no clear-cut evidence for these things, and they don't want to use these people. So coming to vaccine again, so you can't get away without losing lives. And any vaccine you're using at the moment, if you read whole side effects of that vaccine, there's about 1 million of them any patient can have. If you use any H1N1 vaccine or any vaccine, the thing is you can have transverse myelitis, you can have Guillain-Barré, you can have all these things, but people still use it. The same way vaccine in research should go, and it should be well conducted. Trials should go, and we should prevent minimum people getting the worst reaction with the trial drugs. That should be the way. That's the only way you can develop medicine, so ethical committee, local ethical committee, national ethical committee, they should have a role to prevent the minimal damage and minimal loss of life with the vaccine trials. So I'm not a very good person with the research and research ethical committees and all. I've been to said that, but this is the whole idea of having ethical committees, reduce as much as possible. Now, coming to the second part of your question, that's whether the vaccine is going to change the whole thing. I think we have to wait and see that. I don't think anyone can answer that question, because it's still, I remember our Prime Minister said about June, July, or August, there will be Oxford University will be releasing the vaccine and it will be available for whole to use in human, but it didn't happen. And still, I don't think, except that Russia has claimed that there is a vaccine available, I don't think any of the Western countries has clear-cut. They have said within this month or next month you can use the vaccine. It hasn't come, and the efficacy depends on so many things. How many people are going to use it? How well conducted is the research, and what are the number of things looking into. So I don't think it's a thing where vaccine will be sorting out everything within next 6 months or 1 year. I don't think so. That's my opinion about that, about vaccine. If
So yes,
any of the panel members has got any different view,
yeah,
I'm very happy to
I'm
listen
I'd
on
that.
like
that.
to add. I'd like to add.
Yeah,
Um,
yes, yes.
I mean, sir has wonderfully tried to address the question. What I'd like to add is that when we are talking about can we fasten up, can we speed up the procedures, and so when you ask this question, there's a fundamental rider attached to that. What I'm trying to say is these are challenging times, accepted, but even if this is a challenging time, we cannot accept a mediocre evidence. Okay, so whenever it comes to scientific trials, when it comes to um, procedures like drug development, vaccine development, we do understand these are the challenging times, but accepting mediocre evidence would only lead to more harm than benefit. All right, so if we are looking at increasing the so what I would suggest actually is to speeden up the processes like getting regulations, getting regulatory approvals. Maybe you would like to speeden up that procedure. Maybe you would like to speeden up your draft procedure. Maybe you want to speeden up your publishing procedure, right? But you do not want to speeden up your design, the method that you're going to employ. You don't want to skip on the phases of trials that need to be done. You don't want to skip on the consents. When it comes to the ethical aspect of a study, you don't want to skip on these ethical aspects of your studies, because a mediocre evidence, if it is generated, it is as good as a garbage, a tissue paper in the garbage. So that's no use. So recently we saw that Lancet and NEJM, they gave which are two of the most referred to journals when it comes to medical science. The editors, they came up with a press statement saying that we are manipulated, we are under a lot of stress and influence when it comes to big shot pharmaceutical companies, right? So these are some really important aspects to look into. So are we talking about speeding like we want to speeden up this procedure just to get our vaccines out in the market by these big pharmaceutical companies? Though it is desirable that we need vaccines at the earliest, we don't want it at the cost of the lives, as sir was referring to. We don't want it at the cost of mediocre evidence. We don't want it at the cost of skipping the important parts of the trial and getting the vaccines out. So that is something that I'd like to add to this. And when it comes to suggesting, so in your question you mentioned whether this vaccine will be the final cure for this. So I think there's a fundamental problem with that. Vaccine can never be a cure, right? So vaccine is always to protect the susceptible people against the disease, right? So what we are trying to do is to decrease that susceptible population. So we are trying to create that herd immunity, right? So that the coronavirus doesn't get the people to infect, right? So we are trying to do that. So yes, of course it will give us some more command over the current situation. If we have a vaccine in hand, it will help us immunize the people who are more vulnerable. Again, who will get the vaccine, when they'll get the vaccine, who will bear the cost of vaccine, everything remains an issue that needs to be discussed. Who will access the vaccines, right? So there's a lot of discussion that needs to be done on those domains. Thank you.
On the
Shiva,
same
thank
note,
you. Thanks, Shiva.
yeah.
That's very valid point, and thank you for highlighting that very well.
Thank you, sir.
Yes. On the same note, with what Dr. Shiv Joshi have said, I would like Dr. Dabota, ma'am. First of all, let me start by congratulating you and your colleagues, as we all heard the news of, Nigeria has completely eradicated polio in the last week. So definitely that's a bound for applause. And with that note, as ended by Dr. Shiv Joshi, how difficult, I guess, would be to the normal people, if at all we have we develop an effective vaccine, how difficult it will be, and what are the difficulties and challenges we'll be facing, in order to ordinary people to access the same vaccine. What is your note on that?
Okay, the first challenge for us is that in Nigeria, there is still a lot of denial that the COVID-19 pandemic is real. So the first work we have to do is to disabuse the minds of the people against the myths they have and the rumors, for them to accept that the illness is there before they will now accept the vaccine, because that is a big challenge now. There are a lot of myths concerning the COVID-19 infection in Nigeria. There are a lot of rumors going on. Many people feel that it's not real, it's a scam, that the government is using it to spend money. Some people are using that as a source of corruption. So the main challenge, although now there are a lot of jingles on the mass media to educate people about the illness, and especially including the wearing of face masks, which the government have imposed in public places. So the main challenge is for the denial to disabuse their minds, then they will not accept the vaccine. As she rightly said, who will bear the cost will also be a challenge, because definitely the vaccine will not be produced in Nigeria. So it has to be imported. So who is going to bear the cost importing it? Will the people have to pay for it, or will the government give it free? And in Nigeria, we have a lot of slums. We have the rural areas and the urban area. So who gets it first? Those are the challenges that will be there, because will it be those in the urban areas? Will it be the rich or the poor? Will it be those in the slums, or those that are residing in the rural areas? So those are challenges, because some of the rural areas are long hours from the cities. Some are true, don't have motorable ways, in which one have to use waterways, because the rail system within Nigerian cities are not full. So there are a lot of transportation will be a problem. But as I said initially, is to disabuse the minds of the people that the illness is real. Then I think they will accept the vaccine. Thank you.
Thank you, ma'am. Thank you, ma'am. Dr. Shamir, if you could also pitch in, representing a very larger population, like in India, what do you think are the challenges, I guess, as we have it here in India? If at all we, the same question, if at all we develop an efficient vaccine, and your point on the fact that if we have an inefficient vaccine, will it take another step for people to lose its confidence on the very concept of vaccination, which is still prevalent in some part of India and even Kerala? So what is your take on that, Dr. Shamir, sir? I guess the question is clear.
Yeah, I definitely hope that India would develop a vaccine of our own. There is no doubt about that. And
Yes,
and about the time gap, I don't know how fast we may be able to do this. Maybe after one or two countries, maybe third or fourth in the list, we may be. I have a strong faith in our country in developing such vaccines or whatever. Maybe we have a very good scientific temper, and we have good institutes which can develop a vaccine definitely. And once it is developed, definitely it will be made available free of cost throughout the country. That is what I believe, because all the vaccine preventable diseases we could make it possible throughout the country. And about the people's attitude about the vaccine, as Dr. Dabota was talking about her country, almost the same attitude we have seen here also. But during the beginning hours, because now we are in the period of fear factor, we all are afraid about COVID, and if we get a vaccine in the 3 or 4 months period time, definitely people are going to be more accepting to the vaccine definitely. But as the time goes on, suppose the COVID changes its mode, like every year it comes back, it can happen like that also, just like any other influenza or some viruses like that. If it takes a turn like a seasonal virus, and if a vaccine is made available which can prevent this seasonal COVID infection, I don't think there would be a much of acceptance in our country. Maybe in places like some metro cities or Kerala, in the major areas, maybe the vaccine gets some acceptance, but the rural areas, I don't think it would be much of a benefit. And after all these things, if we follow the course of virus like in any other country, like in USA or Brazil or all those places. Almost they have reached a saturation level. They have reached the peak, and now they are all showing a decreased trend. So I think almost a 25% or 30% of population when get infected. So naturally there is a downward trend. So if the virus comes after a 6 or 7 months period, will it become relevant itself is a question, because we have suffered almost everything, and after all these peaks we are getting a vaccine. How far we can prevent a death is again a question mark. So everything is yet to see. We don't know what is going to happen, because we are not even sure those countries are going to get a second wave, like UK or China, whichever country which has already met with a peak level of COVID. If they are again witnessing another peak of another cycle of COVID there, maybe the vaccine has a role there. Otherwise, our country, India, is also going to the peak, is going to peak within a few days or weeks time. And we are already, we have suffered all the losses due to COVID-19. And after that, when the vaccine comes, whether it is relevant itself is a question. So we will have to wait and watch again, as every other delegates have already pointed out. We'll have to wait for everything. We just keep a watch on all these things, and we have to learn what is the plan, what is actually COVID's plan, that we don't know. We have a lot of plans from our part, but the virus plan only COVID knows. So according to that, we'll have to tailor our needs also.
Yes, yes.
I'd really like to make a quick comment on that. When we are talking about the vaccines, we also need to understand that vaccines are going to work for the diseases where we have an evidence for permanent immunity, right? So right now, as of now, we do not know that whether COVID infection is going to provide us a long-term immunity, whether these vaccines that we are going to provide is going to provide a long-term immunity. That is still a question. There is no evidence which conclusively says that after COVID infection, you will get a long-term immunity, right? Because we have also seen certain studies. So there was a recent study done in Shenzhen, China, on 182 people. That was a cohort study. It was done on 182 people, out of whom 20 people came out to be COVID positive after having 2 consequent RT-PCR nasopharyngeal swabs negative. All right. So we are looking at cases of reinfection, and if reinfection happens, how much would be the role for a vaccine? That again we need to think about. So that is one aspect where we need more discussions, people who are experts. And when it comes to India, I think there are three main companies, or I would say pharmas who are actually working in developing vaccines. The prime or the foremost is Serum Institute, which is working along with the Oxford University. Second is Bharat Biotech, and the third is Zydus Cadila. All of them are working on different versions of vaccines. So if one is working on RNA, other is working on a attenuated vaccine. So again, out of these vaccines, which will actually be providing us what we need, we don't know that. So I think there's a lot of uncertainty that is still attached with the vaccine trials, and as everyone has pointed out, only time will tell how it goes.
Thank you.
So I guess let the time tell us what the future is with the vaccine is about, I guess. Thank you.
I just want to add a point on actually, yes, if there is a vaccine developed and if it gives lifelong immunity with single injection, that's well and good. We are really, really blessed with that. But what's happening in UK, every winter, there is an influenza vaccine injection going on in every hospital, where initially it's given for very susceptible people like asthma, elderly, and all these things to go on there. But now what's happening is every person working in the hospital gets influenza vaccine injection during the season. I mean, I have taken only once in my life in UK, and I had the influenza on that year. So I had never taken the vaccine. But most of my colleagues, they are very, very particular for this. And the hospital administration is very particular to get everybody vaccinated. And you will get every day, you will get the letter. And every day, the staff who's assigned to
give the injections. They'll be pestering you to have the injection. But it's up to you to have the injection or not, as I said. So if there is a vaccine develops, that sort of a vaccine can be developed, maybe developing, then you have to have that every year the injection. And that's another thing in the development of vaccine. It can happen that way. So we pray for a single injection, lifelong immunity rather than the regular injections.
Thank you, sir. When you're talking about immunity, I would like to add just one more thing, what Efrain had talked about earlier, that is herd immunity. I've read reports which say that the Swedish model in Sweden, some part of the population has already developed herd immunity and all that. And so I would like to keep an open discussion for this, for you experts to talk on herd immunity and how is this going to be maybe a life changer in the situation.
Okay, so I'll try to attempt that question, and it is highly technical. So let me try to explain it. Okay, if you look at infectious disease modeling, okay, when we try to understand how exactly this infection is going or growing, right? We have these three groups. All right, so one is a group of susceptible people, another one is a group of infected people, and the third one is a group of recovered people, right? So constantly people from susceptible group are moving to the infected group, and people from infected group are moving to the recovered group, right? So between these, there's something called as recovery rate. Okay, so recovery rate is going to help us understand like how fast the people from infected group are going to the recovery group, right? But at the same time, when we are talking about reinfection, okay, so these people in recovered group are again becoming susceptible. That is the problem. All right, so if there is a disease where susceptible to infected and to recovered, and now the disease ends, okay, with a lifelong immunity. Okay, so if you have a chicken pox, you are not going to get chicken pox again in your life, right? So that can be this thing, right? So if such a situation is there, then it's fine. If I have a terminal infection with a long-term immunity, it's fine. Okay, so when you talk about herd immunity, that is where the problem, a basic understanding of concept is important. So when I'm talking about herd immunity, I don't want those recovered patients to again become susceptible. Okay, and by the conventional statistics, they say that around 65% of your susceptible people, if they have the herd immunity, you will be able to curb the pandemic, right? But then the problem lies in fundamentally reaching to that 65%. So are we reaching those 65% herd immunity through infections? Are we reaching it through vaccination? All right, so whatever you do, you need to reach that some critical threshold. It might not be 65% for everyone, but somewhere close to that. All right, so we are looking at that. But when it comes to the zero prevalence, so I mentioned earlier that I am already a part of a zero surveillance that is happening in my district, and what we are finding is a very low zero prevalence. It is just 2 to 3%. All right, so it means that all of us are like sitting ducks. So as soon as COVID comes to our district, all of us are going to get infected. Okay, but if again, how your demographics is going to play a role here, how your context in which you are staying right now plays a role here. Because if I'm talking about my district, which is a population of 13 lakh people, if I'm talking about 20% of them are young people, adolescents, right? So I practically have lesser vulnerable population with me, right? So when I'm talking about herd immunity, that is going to make a lot of sense. So if I'm having more of elderly people with me, I might not have people to take advantage for herd immunity. If I have more of a young population, they might get infected, mild symptoms, it will go away, they'll get immune, and they'll protect the remaining 10, 15 or 20% of people who are still susceptible, but they will get protected by herd immunity, right? So I think when you're talking about herd immunity, the most important thing that comes to my mind is how we are going to create this herd immunity. Are we looking at things like human challenge trials? Are we going to infect our so there are lots of other ways people can induce this immunity. But again, it will come with its own ethical implications, with its own associated costs, and though the goal is same, to create that level of seroprevalence, so that in our bodies we have certain level of antibodies, right? So that idea is there, but herd immunity might come to different people at different costs, and what costs we are ready to bear for this pandemic depends on the respective countries. So if it is the vaccine, okay, well and good, but then who is going to pay for that vaccine? The same questions are going to trouble us again and again, and the answers to those are not that easy. So that's what I feel about herd immunity and vaccines.
Thank you, sir. Does any of the other delegates want to add on, or?
Yes, I would like to add, thanks to what Dr. Sharma and Chief have said concerning the vaccines. As Sharma said, I would like to ask him a question. I'm happy to hear that India will produce their vaccine in a few coming months. Just want to ask, who is going to bear the cost of the vaccine? Are people going to pay for it to get vaccinated, or they'll be vaccinated free of charge? Thank you.
Is it to me?
I guess the question is clear. Shiv asked that India is going to develop a vaccine. How exactly are we going to give it? Are the people going to bear it, or is the
No,
government going to bear the cost for it?
It will be fair. The government will bear the cost.
Yes.
Because now the COVID treatment itself, government is bearing all the cost, including tocilizumab, remdesivir, everything. The government is bearing the cost. All treatment for COVID patients are given free of cost. And adding 1 or 2 points to Dr. Shiv, what about the seroprevalence in Dharavi? There was a antibody study there. I think it's far greater than what your place had shown,
Yes.
isn't it?
Yes, of course. So every country, so every region within our country is in a different phase of pandemic right now. So of course, Dharavi, because it has already reached a lot of cases, it had much higher seroprevalence, of course.
So do you think more than our containment strategies, one part is definitely your containment Dharavi model, and would it have helped in containing the infection, this herd immunity also?
Yeah, of course, sir. When we are talking about herd immunity, what I'm trying to convey is that if we look at Dharavi, so we were just mentioning that it has a population density of around 3.6 lakh people per square kilometer, right? So that's quite a lot of population, and we are looking at, so most of the people there will get infected if there are no measures taken there. But again, the way these infectious diseases they work, if around 65 to 70% of the population in Dharavi got infected during that particular time when the pandemic started spreading to Dharavi, uh, then of course there is a higher chance, there's a very high chance that the remaining 15, 20, 25% people are going to get protected automatically, just like it happens in maybe in tetanus, right? So we also see an example of herd immunity in tetanus. So if most of us are vaccinated, people who are not vaccinated are not going to get the disease, right? Similar sort of thing might have happened in Dharavi, but we do not know whether it happened for sure, because before achieving that stage, we were able to stop the pandemic because of various containment measures, rigorous testing, tracing, and treatment. So that's what I understand. I don't know if I've answered your question, sir.
Sure, I was also thinking the same. The one part is definitely the containment part, the strategies they have taken in Dharavi. At the same time, the zero surveillance has shown a very big percentage of infection, that is asymptomatic infection, that might have also protected people from getting.
Of course, it might have.
Yeah.
Yes.
And I would also add 2 points here. One thing Dr. Shiva had pointed out, the chance of reinfection and the persistence of immunity. And the vaccine development, it need not affect the vaccine. It may affect and it may not affect, because all the mechanisms are different. Even if there is a chance of reinfection, and if there is the immunity is not that long-standing after a natural viral infection, still the vaccine may be able to protect for more years. So even in that context, the vaccine is still a chance. We should not underestimate the possibility of vaccine in preventing a further infection. And the reinfection, about the reinfection, even though a lot of stories came about reinfection from the beginning of COVID virus pandemic, we have only one proof. That is the recent paper which came from Hong Kong, which definitely proved that it is a reinfection because the genomic sequence were different. All other things were just postulates and they couldn't prove. So we need more and more evidence because this much of number of infections and only one case of proved reinfection means we should not be in a concept that the possibility is too high. So again, we need to wait and see what must be the exact percentage of reinfection. Again, maybe another 1 year we will have to wait and see, and a lot of studies are required to arrive at a conclusion.
Yeah, I want to also add to what they've said concerning the developing a vaccine. Having a vaccine for the COVID-19 pandemic or the coronavirus infection is, I think, will affect international travel. Because while the vaccine is out, some countries may want to put restrictions that people coming into their country from other countries may have to show a certificate of vaccination, or they may have to get vaccinated at the airport any way it goes. But I think it's going to have a lot of effect on international travels and international trade.
What I think personally is that is what is going to happen. Once this pandemic shows a decreasing trend, and once the vaccine is developed, in the next year, what we are going to witness, that is only my personal feel. What I think is the vaccine will be restricted like this to some people like the vulnerable people, like the with old age and some and organ damages, and some as Nazar sir was telling, some healthcare workers, and for travelers. That must be the future of the vaccine. Maybe that's only my prediction. Dr. Shiv can add to that.
Sorry, I just wanted to add about the reinfection. I think I don't know about the lifelong immunity, whether after having an infection with COVID-19 you will get lifelong immunity. But I strongly believe at least there is a short-term immunity, because I myself had the infection early February. At that time, the regulation by our hospital was, if your fever is settled or your fever is settled for 48 hours, you can come back for work. So we all went back to work, and we were in the midst of COVID patients again, with a lot of asymptomatic COVID colleagues among us, and we worked there for another 3-4 months. Then we started opening the shops and restaurants and cinema theaters and everything. At that time, I traveled about 10 hours in a flight full of patients, full of passengers from different countries, from London to Mumbai. When I spent Mumbai Open Airport in a closed space in a lounge in Mumbai Airport about another 10 hours. Then again, I traveled from Mumbai in a taxi from 2 people from Mumbai, taxi drivers. Why I'm raising all these things? Initially in UK, taxi drivers were the first one affected. Taxi drivers, security staff, bus drivers, these are the people who affected in Mumbai. Same way, and in London, initial phase. So same way, I came in a car from Mumbai to Calicut, 25 hours. In all this time, I might have had so many patients with COVID. I might have gone through, or I might have just scratched them. I was lucky. I was quarantining for, I was in self-isolation for 15 days, but I haven't had any symptoms. So I had the infection in April, and I'm sure, pretty sure, at my age and all, if there is a chance for reinfection, I might have had the reinfection by this time. But I think at least there is a short-term immunity there. And if it's becoming a lifelong immunity, that's very good, like chickenpox.
Abdul sir, I'm actually very happy that and you have this fortunate moment here that you were also infected and now you're doing well, and of course you are having immunity for that, because that was the basic logic what we tried to implement when we started having plasma donors, right? So plasma donors for severe cases, that was the same logic why we were looking at people who have recovered from COVID, so that their plasma can be given to the severe patients, because there is of course an evidence of immunity, but because the infection is very new, so it was just 5 months before that it started in India. So if I find seropositivity right now, I am I am sure that the infection happened somewhere between this 5 months. But for how long this immunity is there, there is no conclusive evidence, and there cannot be, because of the inherent limitation of the time itself, because we have not went through that time period. We do not know. So it's really great that we have a person here as a panelist who has actually went through this disease and has also survived, is great, doing great now, and you were able to share this experience. Thank you, sir. That is really insightful.
Certainly. I think it has been 2.5 hours that we started streaming. And we have covered almost everything that we could possibly do in 2.5 hours. And I'm extremely thankful to all the delegates who are present here. For ending, let me ask this final question. Okay, Alejandro, sir? Alejandro, sir?
Yes, I can hear you. I just clicked in the
Yeah.
wrong place.
So this something which went viral immediately after he said was, there is no return to the old normal. So my question to all the panelists is, how is the future of healthcare in the post-COVID or along with the COVID? My first, Alejandro sir can respond, I think.
Yeah, sure. I think that's a really good question, you know. I will say we can either have the realistic answer and maybe the idealistic answer, so that will be different, something real, something ideal. I have to say that in the real aspect of this, we do have to change things. We do have to recognize, as I said at the very beginning of this webinar, we do have to recognize the relevance of the healthcare as being a pillar of the whole society in every single country. Now, how much money, because now we have to talk about money, how much money each country is going to provide to this, and how much intervention and participation are we going to have from the communities, that's something really different that we will have to decide. So I think that that's something really important to show and to highlight from this meeting, and is how much are we actually going to get involved in this whole change. So you, as students that are just beginning, you do have a lot of work to do. The the whole activism and the whole events and you do and the learning you get and how you spread it to other students and also to teachers, to your family, that's going to impact for sure. I know from firsthand in India, you do have a lot of student movements that actually had impact on government decisions. So that's how we begin. It's not how we imagine the healthcare system should be or is going to be. It's how we are going to get involved to shape it so it should be better for us. So we are the ones who can decide how much we get involved and how much we work on it and how much we want to change the stuff. So maybe this is like a small crochet. This is an invite for all of you to continue studying, to continue getting involved, to continue teaching, and also asking questions for us as especially because sometimes when you are already working, you lose the sense, you lose the horizon, and you focus on your work, and you forget how important it was when you were a student and when you were just somebody inside the community. So thank you for reminding us how important it is to keep it up and to keep changing. And I will say, hopefully, if we manage to get this involvement in everybody else, we can get some equity and some justice, some social justice around healthcare and any other aspects. I think that there is enough evidence, there is enough money, there is enough resources in all around the world with cooperation, even to build a strong healthcare and to provide it for free to all humankind as a mankind right. So I would say that some countries are a little bit closer to that. I would say Colombia already went through a lot of improvements in the past decades, and some other countries have a lot to work on yet. They even have to worry about their own independence and to be democratic and stuff like that. So that will be different in each country. But I'm sure that we can build a better world, a better country in the next couple of decades.
Yes, certainly, sir. Any of our panelists would like to pitch in?
I would like to ask what
Yeah, definitely.
that's a question that actually generates more questions. We cannot forget or we cannot ignore the fact that the future of the healthcare system depends on the future of our country. And the development of countries and its sustainability actually depends on trade, capital flow, migration. And yet this pandemic has eased all of those. So we need to start asking questions. Where do we want to invest? What are the investments that we're going to be making to make our country sustainable? And if we can develop our countries, then we're going to develop other areas, other sectors in our country. So within our country.
Certainly, yes. Hello? Okay, so I guess it's time to wind up. It was really indeed a great pleasure for us to have all these delegates. Really, we are honored to have you all board here. And we would like to also thank the colleagues of Dr. Dabuta Bore who have joined us. It was really sweet of you being here. And with this, we are winding up not just a session, but also the first season, probably, of MedMeet, International UG Conference hosted by College Union 2020 Government Medical College, Kozhikode. Once again, thanks to one and all for watching this.
Thank you.
One of the most positive things about COVID we are witnessing now.
Yes, yes, certainly.
Otherwise, we couldn't even imagine meeting Dr. Dabota, Dr. Rain. So we will take
Dr. Alejandro.
Yeah. Thank you. Thank you so much.
A pleasure. Yeah.
Thank you, everyone. Thank you, Dr. Chief, for inviting me to the program. Bye. Thank you, everyone.
Thank you, Dr. Dabota, and your colleagues too. Thank you for joining.
Yes.